Welcome to Progenesis Academy 6th webinar. Today we are hosting a roundtable discussion on the topic of surrogacy and egg donation during the COVID-19 pandemic. And we are very pleased to have a very wonderful panelist. We have with us Dr. Mark Trolice. He is a fertility specialist, author, and director of fertility care at the IVF Center. We have with us Dr. David Harari. He is an OBGYN, also President and Medical Chief Officer of Physician Surrogacy. We have with us Kim Pomeroy. He is the Scientific Director for the World Egg Bank. And Staci Swiderski. She is the CEO and founder of Family Source Consultants. And finally, we have Ryan Ferrante. He is an attorney based in Illinois, whose practice focuses on third-party reproduction. Thank you so much for everyone for joining the panel. Let's start first by the question that most clinics wanted to know. They want to know if clinics are currently operating as far as surrogacy and egg donation. For Dr. Trolice, I'll pass the mic to you first. Tell us a little bit if you're taking patients currently.
Yeah, hi, Nabil, and hi, everyone. My pleasure to be with everyone, and thank you for the invitation. So we obviously all had mitigated our risks for the coronavirus by shutting our services down per the ASRM guidance, as well as Florida governor had signed an executive order that prohibited non-urgent surgeries and procedures. So that included IVF and all diagnostic testing. Over this last week, and actually this week, Monday, is when we started opening our services. But I think it's critically important that we adhere to the ASRM guidance and our government to talk about slowly restoring cycles. You know, if we just open up the floodgates, we're going to have a spike in cases, and we have done nothing for mitigation but pause. So what we're doing, we are not jumping right into IVF this month. We're slowly implementing that, spacing patients out. We'll be doing IVF in June. When we resume, we're really prioritizing. We're not going to be opening it up to absolutely everybody. The priorities are the cancer patients who need emergency egg retrievals, patients with severe diminished ovarian reserve because biologic time is of the essence there, and also patients with financial or insurance challenges that warrant a more expedited cycle. I think that that would be an important way to proceed, and those that could delay should, for several different reasons. One is, of course, protection of everyone, the other patients and staff. But the other is that we don't know what we don't know right now about the coronavirus and pregnancy. You know, there's a question of doing cycles, but then there's the question of what kind of a risk are these women taking by getting pregnant during this unprecedented time and confusing time. You know, data is coming at us, changing almost hourly. So what do we do here? We know that coronavirus right now doesn't affect women who are pregnant any more than women who are not. Getting it during pregnancy, about 85% of them are going to have mild symptoms, a third with none. 10% are going to have significant respiratory problems. Less than 5%, pretty critical, that ventilator and much more severe. Preterm labor seems to be a little bit of an increased risk. What we don't know is first trimester, because if you remember, in Wuhan, this started in December. In this country, it seems like February, maybe a little bit earlier, but these pregnant women have not delivered. So we don't know the impact on the first trimester. We know that high fever in the first trimester is going to cause an increased risk of birth defects. And fortunately, at least right now, there is no convincing evidence that there's transmission to baby if mom did have COVID. There's some controversy over some reports, but those assays seem to have been flawed. So I think it's a tremendous amount of discretion and judicious approach to this, counseling patients, ensuring them that they know as much as we know about the risks of what they're undertaking, and just intense attention and diligence toward mitigating risks. So we have our own safety and compliance officer putting together all policies and procedures. And this is a time that, as I said, is unprecedented, but we must adhere for the greater good.
Very good. Thank you. Dr. Harari? Oh, the mic.
I thought Dr. Trolice's dissertation was very thorough, and I don't want to be redundant, although I certainly agree with everything that he had to say. The few cited incidences of potential infection of a pregnant woman or reinfection of the pregnant woman, I understand, were disputed from some data out of North Korea because they may have had false positive tests based on, from the RNA of the virus and having gotten past the infection. So, I mean, I still think, relatively speaking, from an obstetrician's perspective, there is no data to support vertical transmission from surrogate to infant or mother to baby. But certainly I know across the country, all labor and delivery units are being very diligent in keeping the mother and baby separated if the mother is clinically got a fever or any kind of illness at the time of delivery. Additionally, there's all types of mitigation procedures and protocols in place for delivering women in general. And so from a standpoint of surrogacy, I've been very proactive in having updates with our surrogate pool of clients to make them understand that potentially their idea of how this was all going to go down around the delivery may not really be based in what they're going to find when they get to the hospital. Their coaches, significant others and whatnot may not be permitted in the labor rooms at the time of delivery. And all of these sort of things, the integral support system that they normally rely on may not be there because of the COVID epidemic. And so I think it's really important, and I want to get ahead of ourselves, that when we start to open back up, which we are already doing, our agency has worked with IVF centers that are already doing that. It may be in a sort of different fashion, and it may be in a gradual approach. Right now, our surrogates that are moving into cycles are doing it not through domestic flights at this time, because I'm not recommending that they do that. I'm waiting to see when that opens up, but most of them are staying on the ground and going, by car.
Okay. Staci, what are you currently, you are running a family consultant surrogacy program. Are you taking patients? Are you taking surrogates or intended parents right now?
Yeah, absolutely. We are. We are accepting, surrogates still. We have never really stopped. We are just, we're very honest. We let them know that during the matching process, it's going to be one of those waiting, just a time of waiting until the fertility centers can really open up. And the same as David. A lot of the air travel basically has just come to a halt. So we have really been concentrating a lot on matching our intended parents with the surrogates, maybe where they can travel via car, via ground travel. So, even if the fertility centers are currently allowing the air travel to happen, some of the surrogates just are not comfortable with that. And also some of the intended parents just are not comfortable with that either. So a lot of times it's really a case-by-case situation, but definitely we are still accepting surrogates. We are still proceeding with matching surrogates with their intended parents, but in full disclosure, we just, we really inform them with what's going on. And a lot of times too, with the intended parents, they're also different. Even if their fertility center is up and running, as of Monday, it seems like many, are. The intended parents are still kind of hesitant to move forward, even if they do receive that green light. So it's really so case by case with everybody, but definitely we are up and running, and we're still making matches and moving forward.
Very good, very good. Thank you. Dr. Pomeroy, you are running the World Egg Bank. Are you operating currently?
We start our first retrievals next week. And there are some things that we're worried about and some things we're not. to be honest, the biggest fear we have is if an employee or a patient, a donor, comes in and has symptoms of COVID-19, or they're infected with the SARS-CoV-2 virus. Then what do? You've exposed a lot of people. Those people may have to be quarantined. You may have to cancel a cycle. Let's say you're collecting eggs from someone. For their health, it may be best, and to not expose the lab. What would you do if all of a sudden you have a patient that has SARS-CoV-2 in the middle of stimulation and they come into your clinic? You have to decide what you're going to do, and you need to make sure you have all of those agreements written out ahead of time. As far as the fear of SARS-CoV-2 doing something to embryos or eggs or to the patients, that is just very, very unlikely. Not only from the little we know about SARS-CoV-2, but also from what we know about many, many other viruses. And we're talking about human viruses, as well as there's a vast quantity of research on cattle viruses and pregnancy. So it's very unlikely that this virus will do anything that will, I think, do any harm to the reproductive system.
You raised a really important question, is what would you do if your patients contract the virus during the cycle when they're already simulated or at the retrieval or at the trigger point or transfer? We have two physicians here. What's your opinion? What would you do in such a scenario? What your practice would do?
Yeah, I would cancel. You know, there's distinction between urgent and non-urgent, and essential versus non-essential. Now, we all in reproductive medicine feel infertility is essential, obviously. World Health Organization, American Society of Reproductive Medicine, AMA, all consider it a disease as we do. So that's essential. But in terms of urgency versus non-urgency, you have a situation where in the middle of a stimulation cycle, a patient acquires or is tested and found to be positive. Then a lot of these egg retrievals are done in outpatient facilities, not at the hospital. So what you're doing there is then placing, everybody, the entire staff and families at risk of acquiring the virus. And I think discretion should be the better part of valor. So daily screening for staff and patients, and doing procedures carefully. At this point, ASRM and then yesterday SART released guidance that it probably should be avoiding egg donor stimulation cycles in coordination, though frozen eggs certainly should be able to proceed. But I think that those are situations that typically could be delayed, okay? So we have to take a look at priorities all along. We understand that the increase in third-party reproduction has been significant. If you look at from 99 to 2013, we went from 1% of all deliveries into 2.5% of all deliveries in the country. And in terms of international gestational carriers and surrogacy, from 06 to 2013, you went from about 6% to almost 1 in 5. So dramatic increases. But proceeding right now, as Staci was talking about in terms of air travel, we also have to be concerned right now with restrictions of visas and air travel that could potentially put gestational carriers and babies stranded. And Ryan can certainly speak to this more, but I think that we have to just be real judicious in who we're going to proceed with and make it a priority listing as opposed to doors open, back in business. I think it's much too premature. And now we're reading that the projections are potentially more dire. So, I just hope that that we use much more discretion than not.
Thank you. Dr. Harari, so a similar question, but do you have any protocol in your practice that will deal with certain situation like this, where a patient starts stimulation, it's in the middle of the cycle, and then suddenly you discover that they are infected? Do you have such a mechanism in
Well,
place?
basically, I think, fortunately, we haven't seen that happen, at least not from the agency's perspective. But I will say that if clinically you have somebody, for example, from the surrogacy side, who is exhibiting symptoms, we definitely are recommending that they don't continue on into the process. Additionally, there are so many stringent protocols now being put in place by the IVF centers in terms of, you know, the temperature being taken and the distancing in the waiting room and all of these, an accurate history taking. I think most of the centers, medical centers, are going to be very diligent with that. So even if, as an agency, I felt comfortable with my surrogate, for example, traveling and getting there, that's not really a guarantee from my perspective that she's going to pass that screening process at the local IVF center. What is interesting to me is that from a political perspective, ASRM is making a distinction on the egg donor side between fresh transfer, fresh egg retrievals and frozen egg retrievals. One's okay, the other isn't. I don't see what that has to do with someone being symptomatic as an egg donor or not. I think if they're symptomatic, regardless of whether this is going to be a fresh egg retrieval or eggs for banking, we don't want someone who is actively ill coming in and infecting other people. Wouldn't make a difference either way to me. I think it shouldn't be done.
Well, I read that, David, is the distinction is between doing an egg retrieval and thawing eggs. I think that what they were trying to convey is that doing a stimulation on an egg donor obviously can be delayed, but once the eggs are already frozen, you've gone through that process with the potential risk of going through that process. But once it's all done, the eggs are cryopreserved, then you thaw and fertilize and transfer. That's how I interpret it.
Yeah.
Right. I think there's less chance of infection that way all around, right? For IP intended parents as well.
Sure.
Nabil, one thing I'd like to bring up, and that is one thing that we've really taken a lot of care to do, and I think every IVF clinic will be doing this, and that is just severely limiting who can even come into the clinics. I'm talking cleaning people, I'm talking Federal Express people, people delivering packages, spouses. Those people are not now allowed in most clinics. And that's one thing I think that all clinics should be doing to decrease the risks.
Exactly. So the surrogacy and egg donation involve a pretty extensive legal documentation that goes with it. I wanted to ask you, Ryan, you are an attorney that specializes in this field. How did COVID-19 impact the legal process? Is it the same process before and during the COVID time? The mic.
Sorry, can you hear me now?
Perfect.
Okay, sorry about that. So the answer is, and this is a very common answer from lawyers, but it depends, right? There are layers to this question. And just to go back to your first question, I did want to comment on what lawyers have been doing during all of this, right? We didn't necessarily take a pause. From a legal perspective. Obviously, each case is unique. Lawyers in collaborative arrangements who are drafting direct agreements between the parties, we've been listening to our clients, right? We've been asking them what they would like to do. Would you like to continue with the legal process? I'll say that lawyers are still very busy. And for new egg donation arrangements or surrogacy arrangements, this is a time where patients were able to focus on the legal process, and that way when the clinics are prepared to start scheduling procedures again, there's a chance that they've already achieved legal clearance, whereas they wouldn't have otherwise prior to this particular date. Now, like anything else, there's a risk tolerance question that me and my colleagues are finding ways to adapt to the medical schedules which are so demanding, because everything that has been talked about so far, frankly, is far more important than you're going to hear from me, okay? How has it affected the legal process? I mean, we can talk about the way it has affected specific agreements, whether you're talking about an egg donation agreement that's direct between the parties and the terms that have changed to evolve and include language to protect the parties from outcomes that are the result of the coronavirus outbreak. Same thing with surrogacy arrangements. Whenever there's a question about, in the past, about the desires of the parties when it comes to who can be in the delivery room, now we need to consider the possibility that hospital policy may not even allow anyone in the hospital. They may restrict presence to medical personnel only. So there are significant impacts on the agreement that we've always contemplated. The layers are just a little heavier now. That's the way I've described it to my clients. But no, we have not paused anything. Lawyers have not stopped working.
You know, it's interesting that you mentioned that more layers being involved because we had a case where the intended parents were in overseas in China, and they had designated a power of attorney to pick up their child. What we didn't anticipate from an agency's perspective was that power of attorney that was designated crossed the state line, went to the hospital to get the baby, and was turned away at the front door because she was from out of state. And so we had the attorney involved and scrambling to get a second power of attorney to be able to access the hospital, to be able to get the baby and give the baby to the first power of attorney who was designated by the intended parents. So yeah, it can get like multi-layered, like an onion.
Yeah, multi-layered, and the documentation procedures haven't necessarily changed, at least in my jurisdiction in Illinois. But I certainly have found myself on the phone at much later times during the day, speaking to hospital personnel to make sure that the documentation is on file in the proper manner.
Very good. So when we know that the travel ban has affected not just surrogacy and egg donation, but also IVF in general, can you guys tell us a little bit about these impacts, the travel ban impacts, and how does impact your, day-to-day work? And I'll start with Dr. Trolice.
Well, we haven't stopped with telehealth conferencing, and I don't think we ever will, actually. Necessity is the mother of invention, right? So now this is going to be our new normal, and I think we continue. For the betterment of our patients, it's much more convenient for them to be able to have this kind of a consultation before they actually get into treatment cycles. So what we're doing right now is doing local patients, and there are a lot of them backlogged. And I think it's also important in a venue like this is to express the empathy toward fertility patients that have had to delay. These are patients that have been traumatized, another victim, if you will, of the coronavirus. They have gone through enough suffering with infertility, and then lo and behold, they decide to proceed with treatment. They found a clinic that they feel comfortable with, they're ready to get started, and the plug is pulled. And that is really hard. I was a patient for 10 years. Infertility is traumatic, devastating, life-altering, suffocating, overwhelming, every emotion that's negative you can imagine. So we've kept in touch with our patients through lots of phone calls, through a lot of video, social media, through the patient portal, through electronic health record, just to make them know that we're there for them. And I think every fertility clinic should be doing that if they aren't already. And so that's one aspect of things. The other one is that, part of mitigating risk is also avoiding travel. The time right now is just too fragile to just presume we're back in business. We just have to be conscious of that fact. And, we're all taking a hit. Clinics are a business. Of course, we have bills to pay, overhead and expenses and so on. But this is a time that we have to accept that. And we went into this profession for the best interest of our patients. And I think this is the time that we have to demonstrate our commitment to that ethic.
Absolutely.
I think it's going to be really hard too, because you have the patients that are ready now, and then it's just all the unknowns, right? So when do we pick up and just go full force ahead, right? It's, you know, we have many intended parents now who are ready right now to do that. And then some that are just like, whoa, you know, so it's just the unknowns, I think, that really is the scary part for so many people. And especially the ones that you said, Dr. Trolice, who have been struggling for years and years, and they're finally at this place where they can forge ahead with their treatment, and then there's this pause. And it's just for who knows how long for.
Well, fortunately, information is being disseminated in exponential rate.
Right.
So I think in a month's time, this is going to be a completely different picture.
I agree.
We're going to know, hey, we didn't do such a good thing by opening up, or hey, we're open, it's not getting worse. Then we can start increasing the numbers of patients and start to gradually return. But this is the new normal for the for the unforeseeable future. So I think we just have to be cautious.
Yeah, Dr. Harari, I'm going to ask you the same question about travel ban and how that impacted your practice and the teleconferencing. Can you tell us a little bit about that? I think we have an issue with an audio.
I guess mute is on.
Yeah, we have the same policy in place using telemedicine and continuing to do Skypes and WeChats with potential clients overseas. But certainly the travel ban has had quite a moratorium on the number of clients out there, because the majority of them are not willing to do what would be necessary. Just to give you an example, China, if you're a Chinese national, you're going to need to leave. You're going to need to go and get to another country, have a 2-week quarantine in another country outside of China, like for example, Canada. And then after those 2 weeks of quarantine, come back into the US. And then going in the reverse direction, you're going to have the same issue. So most intended parents realistically are not going to want to do all of that traveling with a newborn, leaving the United States. And the vast majority of them, unless there are international travelers or they got stranded in other countries when all this hit, are not going to be willing to take the total amount of time necessary to do this. There's also tightening of monetary controls by the Chinese government. And right now, less than comfortable atmosphere between the two countries. And all these things are going to have secondary ripple effects in the market.
Very good. Dr. Pomeroy, did the travel ban impact your operation in any way as an World Egg Bank?
Yeah, it had a minor effect. We get probably 80% of our donors are local. They're from the Phoenix, Arizona area. So it only affected those that were set up from out of state. It's affected us a little bit in other ways. Shipment, for example. I know that FedEx is only doing priority shipments. And so there have been some things that have been a little bit out of the normal, that have taken a little bit more time for us to troubleshoot and find out how we're going to do things such as shipping. It's also affected the travel of some of our embryologists that go to train people on how to use vitrified eggs. But right now, it's been such a short time, it hasn't had a major effect, I don't believe.
Very good. Ryan, you have been working with surrogates and intended parents, and they may be in different country. How are you handling this transition where the surrogates and the intended parents are not able to communicate face-to-face, or how are you adjusting to this situation from a consultant and legal perspective?
Well, from a legal perspective, just based on some of the comments that were just made, I just wanted to address that. When you have international intended parents seeking to come to the United States, you have to kind of look at it from in two buckets: getting in and getting out, right? And so, from a legal perspective, getting in, there are case-by-case considerations made by the State Department. My understanding is that there has been some success using a national interest argument to prevent hospital resources from being diverted. And there are other considerations, guardianship considerations in the event that intended parents cannot get into the country prior to the birth. Getting out of the country, there is no passports being expedited anymore. There are a few options in order to get documentation to leave the country. There is the emergency exception that that's usually used in the event of a death or serious injury of immediate family. But you could go through the standard processing, which can take 6 to 8 weeks. So it's really about making sure that expectations have been set, so that that based on a lot of the lessons that we're learning, that those are conveyed to existing arrangements, existing intended parents, and so that they know what is going to happen and when, at least based on some of the experience that we've had.
Very good. So when we look at the states that are covered here, so we have Florida, we have Illinois, we have Arizona, and California. How do the states see surrogacy and egg donation during COVID? Are all the states managing it similarly? Are there some differences? Let's start with Florida.
Well, I have not seen any distinction between the type of fertility treatment. It's really just it was an executive order about urgent or non-urgent surgeries and procedures in hospitals or physician practices. Florida has very good laws for gestational carry and surrogacy, and I have not seen any type of distinction covering a particular treatment.
Very good. Dr. Harari, California?
Again, I think this, I haven't seen a distinction made. It's just the generality of travel. It's a generality of patient care for, what is considered to be emergent or non-emergent, or rather elective. Okay.
How about Illinois? Any feedback? You guys know any perspective on that?
Yeah, I'll just say that I'll leave the possible medical outcomes to the experts on the panel, but lawyers are like I said, are proceeding at, obviously still listening to our clients, but we, from the negotiation of direct agreements perspective, we have not really seen too much of a drastic difference. Clients are still willing to proceed because they know that this is part of the process that needs to be accomplished and achieved prior to the beginning of any fertility drug therapy.
As you guys are opening your businesses to manage patients in fertility, including egg donation and surrogacy, what kind of assurance would you give to patients that are seeking those services that will be okay, that they're going to come to the clinic and they're going to be, taken care of, they're going to be screened or some sort of, initial screening? If you had patients in front of you right now, what kind of assurance would you give them, or orientation as far as how they would approach the medical services at this time?
I think most businesses, whether it's a medical clinic or a surrogacy agency or an egg donation company, we all are going to have instituted a policies and procedures manual for safety during the COVID crisis, so that we have specific guidelines on how to screen our employees, how to screen our medical staff, and assuring our clients, whether they be surrogates or patients, that our staff are not infected with the virus, and we're keeping social distancing and isolation mitigation guidelines in accordance with each of our states. And as you know, the states are very much different in that regard. in terms of what you can and can't do. But eventually there will be uniformity in these guidelines across all states. It's going to take a while for that to happen, but I definitely think, screening the core staff that are there, making sure that everybody has been properly tested is going to be instituted.
Dr. Trolice?
Yeah, so what we have done is placed a full one-page sheet to our patients through social media, through our website, and also directly from our patient portal to all of our existing patients on what steps we are taking in order to mitigate risk, and asking them to screen themselves before they come to see us with all the pertinent questions about interaction with anyone that potential under suspicion, their own symptoms, and taking a fever. When they come to our clinic, okay, if they're negative screened for that, when they come to our clinic, only the patient comes through the door, and we have a plexiglass wall that's just been put up that they let us know that they've arrived. We have them go back in their car, and then we notify them through texting when they're ready to come in. We have no patients waiting in our office, okay? So as soon as they're ready to come in, we spread out our appointments apart. As soon as they're ready to come in, we bring them right back in with the medical assistant to once again go through the screening, okay? If they pass the screening from that, then they're able to have their procedure done, okay? Only one person in the room, but prior to patients undergoing actual treatment cycle, our Director of Compliance and Safety talks to them, has a teleconference with them, explaining not just the mitigation of risks, but also the risks in pregnancy. And this continues with every single visit of every single patient, as well as every staff member. And then we have all policies and procedures in place for anybody that is a positive on those. Now, what we're not doing at this point, until probably more clarity, is testing, because I don't think the testing is there right now in terms of sensitivity and specificity to give us the yay or nay over what to do, okay? As a result, we are using screening as our guide, okay? And that's what's being supported actually in guidance that we're receiving. So I think as testing improves, and then we may revisit that. But right now, we're using our best methods of screening.
Perfect, perfect. Dr. Pomeroy, how do you handle this aspect in terms of cryopreservation and handling the oocytes from donors?
That's a very interesting question. I think there's initially a lot of fear about that from people. What happens if you get COVID-19 or the virus from COVID-19 into your cryopreservation system, and will it contaminate an embryo? And there have been a lot of studies done on embryos, eggs, and viruses. Most of that work has been done in cattle, like I've alluded to earlier. And that work indicates that if there is not a receptor for that virus to bind on the embryo or on the zona pellucida, the outer covering of the embryo, then you won't have an issue with the viruses, because they'll be diluted out naturally through all the steps that we go through in the IVF process. An estimation of that dilution factor, just going from recovering the egg until you have a fertilized embryo and you vitrified it, is 6.6 trillion to 1 dilution factor. So there would be no virus left in the system, even if there were viruses in the beginning. There's been a lot of other practical experiments, a very nice one done by Anna Cobo, where she worked with 24 HIV positive patients, Hep B positive and Hep C positive patients. Some of these had very high viral counts, above 2 million copies per milliliter. And when she did the IVF on these patients, she looked for the viruses in the embryos and in the culture fluid, and there was none that was found. So I think this goes to show that we've had this issue in the past. It's not been COVID-19, it's not been the coronavirus, it's HIV, it's hepatitis B, it's hepatitis C, and those can be around anywhere, and they've never been an issue. There's never been a case of embryos in IVF becoming a vector of transmission to cause an infection in a person. So I think we're pretty safe.
Yeah, very good. So, you know, from what you guys were saying, there are now certain procedures at the clinics to reduce risk of exposure to the patient. As far as the paperwork goes, the consent, and have you done any adjustments as far as the clinic?
Oh, absolutely. We have extensive consent process. As I said, our Director of Safety and Compliance does a full telehealth consultation prior, after that, and then review the consent, and then the patient then signs the consent of proceeding. And all that's mentioned is the potential cancellation of cycle in the middle, the potential risk of transmission, what are the risks during pregnancy. Yeah, this has been, this is a brand new process.
Same thing for you, Dr. Harari?
Yes, I think that we've been pretty good about having an informed consent, as well as of educating our intended parents that are interested in moving the process forward. I think that it's really important that they understand that they don't have a false expectation of what we can and can't do, particularly around timelines and travel. So I don't want to get people started in the process and then have it shut down because they can't actually complete the clinical part of that. In fairness also to our surrogates, we don't want to have just an open-ended delay in them undergoing their journeys. And so it's a fine balance to try to keep everybody informed and have everybody's expectations on the table in a reasonable manner.
Very good. Ryan, did you have to change any provisions to match the patient's expectation that are going through the treatment, the fear of getting an infection during the process for both the intended parent or for the, you know, the surrogates? Have you had to change some of those provisions?
Well, so generally speaking, we have, of course, there is a certain level of assumption of risk, right? And so a lot of that is addressed generally. In egg donation arrangements, to address your specific question, the parties like to move as quickly as legal clearance has been achieved, right? And so for the purpose of the agreement, the term is one example that we've kind of taken a step back and said, okay, under normal circumstances, we set the term at about 6 months from the time that the agreement has been signed so that all the parties move right away to accomplish the objective of the arrangement. And so only recently, there are now some uncertainties about whether we might see some future delays. Intended parents might want to consider extending the term of the agreement to 12 months. So that's just one example of an area that has kind of become uniform, at least in the way that I'm advising my clients.
Very good. So we're going to have one more question, and after that, we're going to go to the poll and get the data from the poll. So the last question is, you guys are in the fertility business. You are connected directly or indirectly with the other clinics. What advice would you give to other clinics on how to handle the transition during the COVID-19 in regards to surrogates and egg donors?
Well, I can start. I think at this point, once again, it's a question of priority. You know, I don't think that we should open up the door to all patients that have been waiting, unfortunately, but that's for the greater good. So prioritize patients, cancer patients, severe diminished ovarian reserve, those with pressing financial insurance issues, and doing everybody else as a case-by-case basis. You know, I think in time, there'll be much more clarity. Now, certainly, if a patient is extremely anxious and this affects them psychologically, then that's a special circumstance that has to be addressed and consideration should be given. But I think that we have to realize that this is a unique circumstance and we're looking at the greater good. We don't want to dismiss and reverse the mitigation and making it just a pause, and we're going to spike it back up. We want to flatten the curve and keep it flattened.
Very good. Dr. Harari?
Well, I think it was interesting on my way in today. I heard about an interesting situation, and I like Ryan's perspective on this in Texas, where a woman who had a business, she wasn't in the fertility business, but she was in the beauty business. She had a beauty salon, and she went against the order and opened up 7 days early in Texas. She got cited for it and went in front of a judge who gave her a choice of either apologizing for not following the state mandated guidelines or spending a week in jail. And she refused to apologize, and she spent a week in jail. The interesting dilemma that was raised is she was going to follow the separation guidelines within her shop with the wearing of masks and the 6 feet apart and all that, as well as allowing her clients to make the decision whether they wanted to undergo a haircut or not. So the question that's raised is, was it really a public official's place to make her apologize and feed her a consequence? Or at some point, as we open back up as a society, we can only educate all of us and allow us to make our own decisions as to how compliant we're going to be, or we're going to end up being in a state of much like China, I suppose, where people are roaming the streets and getting arrested and cited and whatnot. So I think at the end of the day, how you determine who you're going to allow to move forward is a very difficult question, and those parameters are going to be individualized by the medical directors, the chief medical officers, the owners of the IVF clinics, and the agencies in egg donation, the egg banking companies themselves as well. I can't give you a straightforward answer on that, but it's going to be a compromise.
Dr. Harari, I certainly don't want to make any judges angry at me. So it's probably a much longer.
We can talk offline.
Share your numbers.
I probably would have said, "Are you sure you don't want to apologize?"
Just do it. Swallow that pride.
Very good. We're gonna go to the poll. Would you like to add something, Staci?
Yeah.
Oh, this was, just on a side note of this is to mention even, say, the pregnancies that are the surrogacy pregnancies. Obviously beyond the fertility treatments, now you have a surrogate who is pregnant, and to envision, their journey and what they were expecting, as well as the intended parents, right? So here, let's say you have this, highlighted OB appointment where 20-week ultrasound, and they had planned on everybody being together for this moment, right? And now all of a sudden the surrogate has to videotape it, so just that full on support, I think, across the board, I think is important to remember as well. So yes, it's affecting the intended parents for sure, but also the flip side of that, the surrogate also isn't able to achieve the journey that obviously she had hoped for. And as an agency, as David would know, like you really go into, when you're matching the intended parents with the surrogate, the criteria across the board, you really want to make sure that you're matching everybody according to what's so important to them, and that's sharing the journey. So I think this, obviously, COVID situation has just thrown a wrench into so many people's journeys across the board. So even like on the surrogate perspective, where they just don't have that support that, that they had initially hoped for, and sharing those moments with their intended parents as well.
Very good. Let's go to the poll. Miriam is going to read the result that we got from the poll and the questions. Miriam, can you please take it from there?
Yes. So we had a poll with a few questions for everybody who's attending the webinar. The first one was, is your clinic currently helping with surrogacy and egg donation? And the majority of attendees said that with 55% saying that yes, their clinic is helping with both surrogacy and egg donation. And then you have 25% that responded no, and 21% saying that it's on a case-by-case basis. And then the second poll question was, how does your state view surrogacy and egg donation during COVID-19? 20% of attendees said that their states viewed it as essential, and 30% said that it was non-essential, or viewed by their states as non-essential. The third question asked if the webinar helped understand the current challenges of surrogacy and egg donation during COVID-19 pandemic. And we have 56% saying yes, that it has, and 43% saying somewhat. And then the fourth question was, after this webinar, are you better equipped to manage patients through surrogacy and egg donation? And we had 54% responding yes. And we also asked question if how likely will you be using COVID-19 RT-PCR and or antibody testing to screen your surrogates and or donors. 48% of the attendees said highly likely, and 36% said likely, and 16% said that it was unlikely. And those were the results from our poll. And then we also had a few questions.
So before we go into the questions, let's take the panel opinion on the polls, and then we go from to the questions. I'll start with you, Dr. Trolice. What call your attention? Anything in particular in this poll that calls your attention?
Well, I think that it speaks to Dr. Harari's point that more people are looking at doing this on a case-by-case basis and trying to restore cycles. I'm just a little bit more conservative and cautious, as much as the psychological impact of fertility is very, very near to me. I'm very worried that we could be sliding back into something that we try to avoid. So I think that you know, it remains to be seen on how things develop. I just encourage caution.
Very good. Dr. Harari, your opinion? The mic.
Sorry about that. The only comment, I didn't want everybody to hear me tapping my foot. The only comment that I have is a question for the panel and for you, Nabil, in particular. This COVID virus is, you know, one of many coronaviruses over the years that have come into affect population groups around the world. But, and it's been very effective in how it attaches to the ACE receptors in the lung and all that. And I know the other problem has been the fact that people that are asymptomatic can shed the virus. Can we safely assume that an IgG antibody titer in someone is, whether they know that they had the COVID-19 infection before or not, but if their IgG comes, the serology comes back positive from Progenesis, can we make the assumption that this particular person, A, if it's an employee in our agency, is going to be protected, and B, you know, I'd like to know how we can use the antibody testing, specifically the IgG antibody testing, versus just doing a PCR test, and how often we need to do the PCR test on these employees.
Okay, so the RNA level in a patient stays for about 30 days. A patient that gets infected keeps the virus for about 30 days. So if you sample at any particular week, you may have less RNA, but you will find some RNA level. The IgM, the short-term antibody, peaks at 2 weeks, and the IgG peaks at 4 weeks, but they do overlap, the two of them. The question is whether that has a value, therapeutic value, or it has a
clinical value.
Clinical value, right? So there is no strict answer to that, but I can say in the recent weeks, South Korea was talking about a second wave of infection, right? People that have traveled outside of the Korea and came back or come to Korea, and they were infected, they cleared the infection, but then again they were infected. That result or assumption of a second infection was based on RNA level only. And then when they tried to recover fluid from a patient and culture it in a cell culture. That's how you culture the virus. You take a sample and you try to infect cell lines so that you can make lots of viruses, live viruses, and you can count them. That test did not succeed. So they were not able to recover live virus on a cell culture system. And then they made it another hypothesis that maybe what they were finding in those patients was just remaining RNA from dead viruses when they were, that there is no second infection, it's just a remaining RNA from the system. So as for now, we don't have any reason to believe that antibody will not protect. But at the same time, we don't have a proof that it will protect. So you are in a neutral position. At least you don't have any proof that having an antibody is not going to do any good to you. It may be, maybe not. If we follow the history, and Dr. Pomeroy has made a few ideas, a few introductions on that side, the history of viruses in humankind, the IgG has protected us over time in the human history, right? So the assumption is it's not going to be any different from SARS-2 virus unless we have something that proves the opposite. So that's my stand on antibody testing.
Yeah, I think right now, the real-time PCR testing, about 70% sensitivity. Then when you're getting into the assays, the predictive values are going to be based on the prevalence in the community. So if you have a low prevalence, the positive predictive value is not going to be good. High prevalence, negative predictive value is going to be better, but it comes down to there's asymptomatic transmission, and there's also no evidence that having these antibodies is definitive proof that you've had it. And secondly, that you are going to be immune to the virus again. We don't know if it does or it does not. So testing, I think right now is still ambivalent, and we don't have the definitive indication of who to test and how do we interpret the tests.
So as far as sensitivity, the rapid test has 30% sensitivity. The ELISA test has 90 and above % of sensitivity. Right. So in any case, if you wanted to test employees or patients to look for IgG, the ELISA test is the medical grade test that one should use, not those commercial, right. End consumer type of tests.
Well, that's what the FDA is basically put everyone on notice, giving them 10 days to get to that level of sensitivity and specificity.
Correct. Very good. Let's get some questions from the audience. Miriam, can you please share with us the questions?
Yes, we have a good number of questions that have already been answered by the panelists, but I'll go over the ones that haven't. The first one was for Dr. Pomeroy. They're asking if you're stimulating donors, and are you concerned about their eligibility with the FDA?
Well, right now, this coronavirus, SARS-CoV-2, is not on the FDA's list of diseases of importance. And I think the reason is not because it's not important and they're not concerned, but it's because they don't have enough facts to tell you what to do with it. They have offered 3 questions to ask people regarding whether, or maybe it's 2 questions, whether, first of all, you've had symptoms or been diagnosed with SARS-CoV-2, or have you been in contact with anyone who's been diagnosed with SARS-CoV-2 or has symptoms? And those are the 2 important questions. And I can see Mark nodding his head up and down because that's probably what he has on his forms that he asks his patients, and that's what we ask all of our donors. But then you have to ask, in our situation, what would the fear if a patient had SARS-CoV-2 as a donor? The fear would be their health and the health of those people coming into the World Egg Bank. It would not be a fear of really producing eggs that would be bad eggs that would then infect other people. I don't think there's any data for that. So that's the main thing.
I just, we have Cryos International in Orlando as an egg donor bank, and we've talked, because I'm the director of the egg donors bank, and I have shared that it's not just a question of whether it's affecting the egg, it's a question of mitigating risk, right? Egg donors are at higher risk of hyperstimulation. Fortunately, that is low. If an egg donor does turn positive during the cycle, do we have the correct personal protective equipment to ensure that patients, their families, staff, and their families are going to be safe? So this is the reason for the ASRM and SART guidance of limiting the numbers of patients that we do undergo egg retrievals, because it's so in flux right now. We just don't know what we don't know.
Yeah, maybe I could simplify something too, because this is the same thing that Mark and David have been saying throughout this presentation. The fear that we really have, the big risk that we have in doing this type of work is in infecting patients and healthcare workers. That is what we're most trying to reduce, because that's what we know is going to have the biggest effect.
Thank you. Next question is actually another donor question. And Christian asks, would you test donors and how often?
I think Mark just answered this question previously. What do the tests mean? That's what we have to know. We have to know the false positive rate, the false negative rate, to know how well these tests are and the time period in which they can detect whether someone has a current infection, which is what we'd be more concerned with than whether they had a past infection, because we don't know what that means now. And that would be an antibody test, that last one. The first one would be using a ELISA test or a PCR test.
Okay. Next question is from Megan, asking, how would you go about consulting intended parents who are looking to using an international egg donor? Would you recommend holding off?
Well, I think we talked about this earlier. Right now, with international restrictions on visas and travel, there's the potential that gestational carriers and babies could be stranded. It's just too fragile right now to be able to provide enough assurances and guidance doing international surrogacy. I would feel that would be something to hold off right now.
And how about you, Dr. Harari? What would you say?
I think let's look at it from two different perspectives. From the surrogates side perspective of things, one of the things that my concern of my agency has been, not only is the IVF center in which they're going to have the transfer, are they open and are they willing to do a frozen embryo transfer, but also the monitoring center access for my surrogate. Will she be able, after that transfer, to have her early pregnancy monitored without her having to get on a plane? So the caveat has been, if those two can be answered by, yes, the IVF center is willing to do the transfer, and yes, she's local so that she can come back there for continued monitoring, or she can go to a local monitoring station that is seeing patients. We have both of those hurdles have to be met before we will allow things to continue on to legal and whatnot. From the intended parent's perspective, the understanding is that unless they're willing to start traveling the world to be in quarantine before they get here to pick up their baby, that they have a designated power of attorney and all the contracts are in place for that. It's important for them to understand that the access of the surrogates to their obstetrical care may be done by telemedicine. It may be remote. And so as Staci mentioned earlier, you're not going to have some of the one-on-one personalized experiences during that pregnancy. And the intended parents have to understand that too. Huge disruption of obstetrical care in this country over COVID and prioritization of patients. their access to the OB has really, really been impacted. And the intended parents have to understand that as well.
And I think with that, that concludes all the questions that we've received.
Very good. Fantastic. Well, I think we're gonna just leave last comments from everybody. If someone wanna add one comment, and then maybe we'll start with you, Staci. Tell us a little bit about Family Source and what you guys do for patients.
Yeah, absolutely. So we are headquartered in Chicago. We opened the doors back in 2007, so it's been a little over 13 years now, and we facilitate the surrogacy and egg donor journeys. We do the matching process, we handle the matching process, and then facilitate until after the baby's born. We facilitate approximately about 200 or so arrangements per year, and we work with intended parents worldwide, of course, but yeah.
Cool, very good. Dr. Harari, tell us a bit about physician surrogacy.
Physician surrogacy was started in 2015. We, prior to the coronavirus, were having a pretty robust increase in the number of surrogates. Prior to the beginning of the year, I think we had 200 surrogates in 6 states that were actively enrolled in the process, either from embryo transfer or carrying to term. And we have continued to recruit as well. Interestingly, my perspective on this is going to be that we're going to have a multitude of people wanting to become gestational carriers due to the unbelievable economic impact that COVID's having on families and people losing their jobs. So I think, interestingly, probably by the time of the 4th quarter comes, we'll have more surrogates than we have intended parents, which has really never been that way. But I predict that's one thing.
That'd be interesting, right?
Yeah, absolutely.
Dr. Pomeroy, tell us a little bit. I know most people know about the World Bank, the Egg Bank. Tell us a little bit, give us a quick introduction of what the World Egg Bank is.
Sure. The World Egg Bank is out of Phoenix, Arizona, and that's the only place we're out of. The main reason is we do everything. We're one of the few egg banks that does not send out and get eggs from other groups. All the eggs that we have in the bank have come from our physician. We have one embryologist that has done all of the vitrification. It is a very controlled so that we can provide the highest quality of eggs possible. There's variability in everything that we do in reproduction, and we try to reduce it as much as possible. I also agree that there's going to be a large number of people waiting at the doors of IVF clinics, whether you're using donor eggs, surrogacy, whatever, that are going to increase the amount of work that these clinics have. But I still think we're going to do things differently than we did in the past. And we're going to see more video conferencing, and we're going to do things that are going to be done much simpler because of what we've had to go through with COVID.
Very good. Dr. Trolice, tell us a little bit about your practice.
Sure, Nabil, and thank you all. It was a wonderful discussion. I was honored to be a part. We have an academic fertility practice in Orlando, Florida. I'm a professor at the University of Central Florida, so I'm on faculty. I teach the residents and the medical students. And I'm also working with Ryan on the Resolve Advocacy Day that's coming up on May 20th. So I invite everyone to please contribute in any way possible, because infertility is a disease and it deserves to be covered by insurance. I am working very hard to get this in Florida and to add to the numbers of mandated states across the country. So our prayers to be able to do that and eliminate the financial burden of infertility to patients.
Very good. And you forgot to mention that you're an author. Because
oh my goodness. So you're the
shout out.
So you're the one who bought it.
We bought several. We bought several. So what we do, and I hope many physicians would write books, because this is a really nice introduction. It's called Overcoming Infertility. It gives you an overview of the entire process, fertility treatment. it's highly recommended for any employees, whether they are in the medical aspect or even in the customer support or any aspect that touches the IVF, to read it, because again, it's going to give you an overview of the entire scope of infertility treatment. I have to thank Ryan, is not here, he has to leave earlier, and I have to thank him. Ryan is an attorney who specializes in surrogacy and egg donation. If you guys want to reach him directly, I can facilitate the contact. He's based in Illinois, specialized in Illinois law. And with that, I would like to thank our wonderful panel, Dr. Trolice, Staci, Dr. Harari, Dr. Pomeroy. Thank you so much for joining our 6th webinar. I would say that next week we will have another webinar, so stay connected, check your email, and thank you so much. Have a great day.
Thank you.
Thank you, Nabil.
Thank you. Bye, everybody.